Hello, everyone, and welcome to the first edition of the Diabetes Care Summit. I'm Dr. Barbara Akimbua, and I'm your health buddy. This summit is for you if you've been diabetic for a while and you've been struggling with keeping your blood sugar controlled, either because you have problems knowing what to eat, when to eat, how to eat, what else you need to do to keep healthy, or you do know these things, but it's difficult to be motivated. It's also for you if you have an elderly parent who is diabetic that you care for, and you find juggling medications, clinic visits, meals, and then illnesses in between overwhelming. Or you're a beautiful married woman and all you would love to have is a normal pregnancy and delivery. And instead, you keep having miscarriages and stillbirths as a result of complications of diabetes. Or it could be your husband. He is the one who's diabetic. And during sex, you have problems. It's either most of the time he can't get it up, or he has other problems while you're having action. It's also for you if you're a health enthusiast and you believe that prevention is cheaper and better than cure. And so you'd like to learn anything you need to know to stay healthy. During this summit, you listen to loads of interviews by different specialists, including myself. Some of the interviews are short and some are not so short. But I'd encourage you to watch each video till the end because there's loads of important health information and you're getting it all for free. So, once again, welcome to the Diabetes Care Summit. And don't forget, I'm Dr. Barbara Akimbua and I'm your health buddy. See you on the healthy side. Today we'll be talking about what you need to know about your eyes and diabetes. We interact with the world through our eyes. There's a popular saying that the eyes are the windows to the soul, but I think the eyes are the windows to the world because we see everything that we interact with other senses. And if our eyes are affected, then it's a big impediment. So today I'm going to be discussing with a colleague that is a specialist. I'll allow him to introduce himself and then we'll take it from there. So over to you.
Okay, thank you, Barbara. It's a pleasure to be here this morning. My name is Olufemi Oderindo. I'm a consultant ophthalmologist and vitreoretinal surgeon with the Eye Foundation Hospital Group.
Wow. Thank you. What is a vitreoretinal surgeon? I know ophthalmologist is an eye doctor. What does a vitreoretinal surgeon do?
Okay, so a vitreoretinal surgeon deals with diseases of the vitreous and the retina. So the vitreous and the retina are the two major tissues at the back of the eyes. Normally, we divide the eye into the anterior segment and the posterior segment. So most of the posterior segment is made of the retina and the vitreous. And so that's my own specialty.
Okay, so you're a super eye doctor because you've taken it a step further. Okay, so how do the eyes work? How do we see the images? How do we see the things we are looking at? Let's start from there.
I think it's a beautiful design that God has made the eyes with. It's unique. Our eyes are in front. And so when images come, usually it's by light reflected on the surface of those images. We are able to, the light passes and is refracted through the media in the eye, the cornea, and the lens are the two major media. There are other media. I can divide the cornea into the anterior cornea and the posterior cornea. Anyway, they refract the light and it's focused on the retina. So the retina picks up the light and then sends a signal through the optic nerve to the brain. And the part of the brain where interpretation is done is at the back here. It's called the occipital cortex. So that's a summary of how the eye works.
A simple way. So I'd like us to go over that a bit. So the eye has different parts.
Yeah.
And one of them is the cornea, like you mentioned.
Yeah.
Which is in front.
Yeah.
And then the retina is at the back of the eye.
Yes.
So when the light passes through the cornea and the parts in the middle of the eye, it focuses on the retina at the back of the eye.
So that's the model of the eye. Yeah.
Okay.
And so this is the cornea.
Can you raise it up a little, please?
Yeah.
Okay, good.
Okay, so the light comes in through the cornea and is refracted through the cornea. It's refracted through the lens, and then it forms an image on the retina here. There are photoreceptors on the retina that pick up the image and then send it through the optic nerve to the brain. That's just a summary. And you can actually see that if we draw a line here, we call this the anterior segment of the eye, and this the posterior segment. And you can see that the posterior segment actually makes up about 4/5, about 80% of the eye. And the whole area here is highly vascular. You can see the vessels there. And inside this place is a fluid that we call the vitreous.
Wow. Okay.
Yeah.
So you are a specialist in the retina and the vitreous.
Yes.
The back.
Exactly.
Okay. All right. So what problems make people need glasses? If that's how the eye works, why do some people need to wear glasses?
Okay, so the refractive strength of the eye varies, the cornea varies, and the lens varies. And also the size of the eyeball itself. So imagine that this eye is so big that it's as big as this. The light may not be able to be exactly focused on the retina. So you will need to put a lens here to diverge the light so that it can be focused more to the back. It's the same thing for when the eye is smaller. So if the eye is smaller, you need to use a converging lens to converge the light onto the retina. So those that have larger eyeballs are relatively short-sighted. So they use diverging lenses, and then those that have smaller eyeballs are relatively far-sighted and need convex lenses. So refractive errors are the errors in the eyes that can be corrected with glasses. And majorly we talk about 3 of them. If we look, there are more than 3, but majorly there are 3. There's the short sight, there's the long sight, and astigmatism. So astigmatism has to do with the curvatures of the eye. If it's too steep, it will affect the place where the light is focused on the retina. So those 3 areas. So people who use glasses are either myopic, astigmatic, or hyperopic.
Which is the same as short sight, astigmatism, and long sighted.
Yeah.
Hi, have you heard of Soyo, the new diabetes care app? Studies show that the best medicine to take for diabetes is to get education about it. Because if you understand how it affects your body, you'll know better what you need to do to fight it. It will also help you to take care of someone else with diabetes. With the app, you don't just get education, you also get to make your management plan either for yourself or the person you're taking care of. There are also lots of other features like meal plans, medication, and other reminders to keep you on track. And if you fall off, don't worry, just get back on. This is how families can live healthy and happy with diabetes. Don't be left behind. Download the app at soyo.web.app to care for yourself or someone else with diabetes. So are these the same problems that people with diabetes have with their eyes, or is something different?
Okay, so it's there are some diabetic patients who will have relative myopia or hyperopia, not as a result of the size of their eye, not as a result of the size of the lens, not as a result of the cornea, but as a result of excessive sugar getting into the fluid in the eye and therefore increasing the refractive index of that fluid. So diabetics may become relatively myopic or hyperopic. And some of them, if they notice very well, they'll notice that times when their sugars are poorly controlled, they begin to have blurry vision because the sugar goes into the eye and then affects the refractive medium. Now, that is just one of the earlier things that happens. If there's prolonged hyperglycemia, eventually there will be changes in the vessel at the back of the eyes. What hyperglycemia causes, there are a series of things it causes, but one of them is that the cells, the platelets, they become more sticky. If you put water in sugar and it dries on your hand, you see it's very sticky. So if
Yes.
hyperglycemia, if there's high sugar in the vessels, the platelets become very sticky. They stick together and they can occlude the vessels.
So they
When
block the vessels.
they block the vessels, when they
Okay.
block the vessels, the body is going to try to compensate for that blockage by creating new vessels. Unfortunately, those new vessels are made in a hurry. They don't have all it takes to be able to form and have the strength. And rather than having 3 layers, they have 1 layer. And so as soon as blood flows into those vessels, they break. And there's a big cavity here. When those vessels break, they empty the blood into this cavity. And that's vitreous hemorrhage. The series of things I've described is what we call diabetic retinopathy. Diabetes can affect every aspect of the eye. Starting from the cornea to the lens, it can encourage the formation of cataracts. It's also, yes, so diabetes affects absolutely every aspect of the eye. That's why it's a very peculiar disease.
Okay. So does it do this suddenly, or does it happen in stages? And how will the patient, how does it affect if it occurs in stages, how does it affect the eyesight at each of the different stages? What would be observed?
Yeah, so differently, sometimes it could happen suddenly, but more than 90% of the time, it's a gradual process. And it's like I've spoken about diabetic retinopathy. It usually starts from the non-proliferative stage, where the vessels are just showing as leakages, or sometimes there can be abnormal fluid. You understand that if there's excessive glycemia, the osmosis, it can encourage osmosis, therefore fluid can move into the retina, and that's what we call macular edema. All those things many times will happen early. So we have the non-proliferative diabetic retinopathy, and then we have the very dangerous one, the proliferative diabetic retinopathy, that eventually leads to blindness. It's one of the leading causes of blindness all over the world. Actually, we are looking at vascular diseases. Diabetic retinopathy will be one of the leading causes of vascular diseases that leads to blindness all over the world. And uninterestingly, it affects the working age population. So that makes it very, very, very deadly. Now, most of the time, in the early times, in the early non-proliferative stages, there might really be no symptoms at all. So the only way that someone can know, and this is the best time to catch it, is when you get an examination. Routinely at the point of diagnosis, every patient that is diagnosed with diabetes should have an eye check. And then depending on the risk factors and depending on what the findings are at the first visit, they can be given subsequent visits. If someone is diabetic and is well controlled and doesn't have any symptoms, we could see them in 4 to 6 months. But where they're having symptoms or you can see some signs, then it depends on the signs and you can pick up when to see them. So it's important to do screening for diabetic retinopathy. That's the only way we can guard against visual loss. Because unfortunately, most patients are going to wait until they begin to notice their vision is blurred. When a patient starts noticing that, what it means is that the vision, there's already some significant damage.
Okay. So it's more difficult to treat at that stage.
So it becomes more difficult to treat. So the best thing is to catch them early and begin treatment early. Now, it's also important for us to know that the longer a person has been diabetic, the more likely the person will have diabetic retinopathy.
So please say that again. Please.
The longer a person has been diabetic, the more likely the person will develop diabetic retinopathy.
Okay.
At the early diagnosis, there are variable statistics from the diagnosis and it depends on how it is. But we all know that at about 30 years, when a patient has been 30 years, when there are patients who have had diabetes for 30 years, 90% of them will have
diabetic retinopathy.
So very important to note that. And then other factors like glycemic control, how good has the control been? Other factors like there are other risk factors like anemia, systemic hypertension that contribute to progression of retinopathy faster than it could be. Even pregnancy.
Pregnancy.
Yeah, I know your eyes will change when I say pregnancy. So it's very important for people to be monitored closely. It doesn't say you shouldn't get, ladies, it didn't say they shouldn't get pregnant, but it means that you need to monitor it very well because of the whole physiological changes that happen in pregnancy.
So are there treatments for the different stages of diabetic eye disease, the early stage, the late stage? What are the different treatments?
Okay, so there are so many, and thankfully within the past few years we've had a lot of advancements in the treatment.
Okay.
So traditionally it was laser photocoagulation. Laser is an acronym for light amplification by stimulated emission of radiation. It's a light source that we can use to burn off abnormal vessels. That light source too can be used to modify the positioning of fluid within the eye. It can also serve to do a number of other things that help with diabetic retinopathy. So laser photocoagulation, of course, like I said earlier, management of the diabetic state. If the diabetic state is managed very well, it reduces the risk. We have some studies like the DCCT studies that tells us that strict management of strict glycemic management in diabetes, reduces the rate of progression. And so recently we also have anti-vascular endothelial growth factors. There are injections that can be used for macular edema, for proliferative diabetic retinopathy, which really do help a lot. Then when it has become bad, surgery. Surgery for diabetic retinopathy is highly technical. It's
where you come in.
Yes, that's why people like me come in. But I'll tell you the truth that I'd rather see a patient early and apply laser than have to do what we call a vitrectomy.
Okay.
Because at that point, there's a lot of damage. At that point, some of them will have had what we call a tractional retinal detachment. The retina is already out of position. There's no blood supply to the retina. A lot of the retina cells are dead. There's a lot of fibrosis. It looks murky in some areas. It takes a long time, sometimes 2 hours surgery to be able to sort this out. And even after that is sorted out, there's no assurance that the patient is going to get 100% vision back. And even such patients, usually we have to cancel them, tell them the prognosis is guarded. So the key to diabetic retinopathy still is early diagnosis, early treatment, and then the outcomes are better.
Okay, so I would like us to put this in perspective. From what you've said, prevention is better than the cure or the treatment.
Exactly.
And prevention has to do with screening.
Yes.
What screening do patients have to get? Because a lot of patients will say, I go to get my eyes checked. They check my eyes when I'm getting my glasses. Is that the screening, or there's something?
Yeah, so my advice would be to see an ophthalmologist.
Okay.
Many times, many of our people don't know the difference between an optician, an optometrist, and an ophthalmologist. An ophthalmologist is a medical doctor. I studied medicine. So you do medicine first, then you now specialize in the eye. So because the ophthalmologist will have a broader view and be able to look and dilate the pupils and have a look at the retina very well. In more developed countries, it's a routine. Once people are diagnosed, they are sent to the ophthalmologist for examination and then subsequent follow-up. As long as a patient is diabetic, he will need to be seeing the ophthalmologist. And that's what many people don't like, but that's the truth. You will still, even if everything is stable, it's good to keep an eye on it. And so they will examine you. Now, there are not a lot of effort is going on presently. I also know that the Ministry of Health is trying to set up a national screening program for diabetic retinopathy. You should know that it's a Herculean task. Yeah. We're talking about 200 million people living, some of them living in places that have very little access. So, but it's important that we start from wherever we are, and we are able to pick up people, anyone that we can pick up, anyone that we can save, we should save. So screening is very important. And even if your doctor, I don't expect that, but I expect that doctors should send diabetic patients to ophthalmologists for screening. But even if your doctor does not, you should request to check your eyes. And in diabetes, you want to check the eyes, you want to check the kidney, you want to check the heart, you want to check the peripheral nerves. Those areas are important in diabetes.
I like what you just said, because the body, no organ in the body functions in isolation. The whole body is a unit. So if one part is affected, eventually the rest of the body is affected. So that's good. So I'll just ask now, the cost. What is the cost of screening, the cost of versus the cost of the laser treatment or photocoagulation, and then the cost of surgery, so that people know that they can see if you leave it too late, this is how much you'll be needing to spend. If you go in somewhere in the middle, this is how much you spend, versus if you screen, this is how much you spend.
So it's very difficult to put costs.
Okay.
Yeah, you see, I've tried to simplify everything, but let me put a little more complexity into it. So the laser you talk about, there are different types of lasers. First of all, we could be using an argon laser, you could be using a semiconductor laser, you could be using a yellow laser. That's one. Two, the different techniques. You could be doing a focal laser, you could be doing a pan-retinal photocoagulation, you could be doing a quadratic photocoagulation. So all those things they cost differently.
Yeah.
But generally, lasers will cost by far lower, we can use this ratio probably times 5 of what you will spend on a laser treatment is what the surgery will cost, between times 5 and times 10 actually, depending on how much needs to be done. So if the patient misses the time of the laser and has to go in for surgery, it's probably going to spend between times 5 and times 10 to have the surgery done. And then the outcome is not even likely to be as
guaranteed.
Yes, as good as if he had laser earlier. So all votes go for early treatment.
How much is screening on average?
So screening, for some places you can get screening done free of charge. So we have, for us, we do have our public outreach, and we also have private outreaches that we go and screen diabetics free. If you're going to the clinic, you should, I think the screening is just the cost of the consultation. I don't think anyone is going to charge you extra. It's a diabetic retinopathy screening, pay so. It's the cost of the consultation in any doctor's hospital.
So people should be rest assured that it is not, it's not good. They don't need to pay an arm and a leg for screening.
No, not at all, not at all. It's usually the cost of the consultation in every doctor's hospital. So I don't think any doctor charges extra.
Cheapest laser surgery. I want to pin you on that.
You just want me to say something. So I'll
Yes.
give you a range. I won't mention the institutions.
Okay, that's
So
fine.
I know public institutions do laser, one session of pararetinal laser photocoagulation between 10,000 and 25,000 naira. And that's public institutions. And then I know for some private institutions, it's between 50,000 and 150,000 naira. So those are ranges. And like I've said, there are different lasers. There are different generations of lasers. So, I mean, laser is a whole lot of things. So if I was using an older generation of laser that I was able to get cheaper, then I can treat the patient cheaper. But if I'm using a top of the range, newly invented laser, then it will be more expensive. So, but that's about the range in Nigeria.
So how can family members help diabetic patients? Like, from your experience?
Well, yes, I think it's the support. It's very, especially if one person in the house is diabetic and the others are not. It's the understanding and the support, because the person will be eating differently from every other person. And you're going to have to prepare their meals differently if it's only one person. If the whole house is diabetic, okay. So everybody eats the same thing. But in most cases, it's not like that. It's just one person or two people. And so their food has to be cooked differently. They can't eat this, they can't eat that. And the whole family is always tempting them, baking cakes every day with icing and filling so they have to watch, because diet is an integral part of the management of diabetes. And also the emotional support. For patients that take insulin injections, it's not interesting. Every day you prick yourself with a needle. Many times patients get fed up and tired. Just tired of pricking themselves every day. And emotionally, some cry. So the emotional support has to be there. And the family members themselves have to understand the disease. Otherwise, sometimes they think those individuals are malingering. They think they're tending. So they have to understand the disease. It's just the same for most other diseases. Systemic hypertension too. The hypertensive person will eat a low salt diet or no salt diet. So everybody puts salt in their food, and they have to prepare the individual's food without salt, and it's, people can get angry. Why are they, but so you have to understand, the family too has to understand. And sometimes we do educational meetings for our patients, and we allow them to bring their family. And we encourage them to bring their family, because family support is very important to the success.
All right, final question. What advice do you have for diabetics and their family members? Any?
Well, okay, so right now, diabetes is not a death sentence. I think that's one of the fear. Someone said that, they said we don't live long. No, I do have a lot of patients who are in their ninth decade, eighth and ninth decades of life, and they are doing well. I also have family members that are diabetic. So it's important to stay close to them. It's important to counsel them. It's important to help them emotionally. And also, there are a lot of financial challenges.
Yes.
Tell you how much they spend on their medication in a month, you probably will think they're telling lies. Well, it's so expensive. And so it's good to lend a helping hand. We are a communal people. I know everybody wants to be like Oyinbo, but now we're Africans by nature. And so we're a communal people. We don't throw our old people to the old people's home when they grow old. We keep them with us. We take care of them. And so I think that's a good support system from the family. And if it's well managed, the patient can live in fact, there's so many people living with diabetes.
That's true.
So many top government officials, so many actors, so many people, CEOs, so many living with diabetes, and they're doing well. And so it's not a death sentence, but such people, they need our support, and we should be willing to give it.
Thank you so very much, Dr. Femi. I'm sure I learned a lot. I'm sure others have learned a lot too. And thank you for finding the time to do this. I'm glad you took my advice and watched the video till the end, and I hope you learned a thing or two. So don't forget, watch the next videos because there's still lots of information that will be really beneficial to you. Don't forget soil.web.app. Download it now. See you in the next video. Bye.